Okay, everybody, we're going to pick this up with adrenal drugs. Should be taken with food. I couldn't jump right there with the recording, so
especially if it's one of the naturally occurring
Chapter 33,
opioids,
adrenal drugs,
like morphine, because it produces more
we talk about this, like I already mentioned,
because of the anti-inflammatory process.
Take that with food, because of the CNS might have, and actually this fits right in with what we're going to talk about next week as well, with the autonomic nervous system, peripheral nervous system, drugs that we give in relation to that. So when it comes to the adrenal gland, located right above your kidneys, there's two parts of the adrenal gland, the cortex, which is the outer part, and the medulla, the inner part. The adrenal cortex is responsible for producing corticosteroids. Cortico means cortex, so there's steroids that come from the cortex. If that helps you keep that in line. Now, corticosteroids, there are two corticosteroids that the body produces from the adrenal cortex. The glucocorticoids, primarily cortisol, and the mineralocorticoids, which are primarily aldosterone. Now, glucocorticoids are such named because they affect the body's glucose. Like I said, cortisol is the primary one that you think of. Cortisol is basically the body's natural version of prednisone, which is the synthetic version that you guys are probably familiar with. And as you already know, with prednisone, it raises the body's blood sugar. We'll kind of talk about that. And cortisol does have anti-inflammatory properties. Mineral corticoids, these are the corticosteroids that might affect minerals, which means electrolytes. Primarily, like I said, aldosterone. And think about how aldosterone works. You talked about this during your fundamentals course, I'm sure. Aldosterone causes the kidneys to reabsorb sodium and excrete, get rid of potassium. So it affects the minerals, the electrolytes in the body. Now there's another hormone that is produced by the adrenal cortex that I would like you to be aware of. Just put it in the back of your mind, because when it comes to signs and symptoms, it's going to help that part of the discussion make a little bit more sense. But the third hormone that comes from your adrenal cortex are the androgens. And androgens serve as the precursors to the male sex hormones, like testosterone. But also, androgen serves as the precursor to estrogen, the female hormone. So these secondary sex hormones also have the precursor being released from the adrenal glands. That will be important to keep in mind later when it comes to side effects. And then we have the adrenal medulla, which is the inner part of the adrenal gland. And the adrenal medulla secretes the catecholamines. Now these are your fight or flight hormones, the epinephrine, the norepinephrine. But I want you to keep in mind all of these hormones on this slide that we've talked about, these are stress hormones. So when my body's experiencing stress, my body's going to produce more cortisol. My body's going to produce more aldosterone. My body's going to produce more epinephrine, so keep in mind, stress will affect all of these hormones as well. And basically the brief statement on the bottom of the slide there is the feedback process of hormone regulation. Basically, whenever it's this whole concept of negative feedback, that whenever I have a lot of these hormones in my body's going to sense, my neurological system is going to sense that I have plenty of these hormones, and it's going to tell my adrenal glands to decrease the production, to bring the level down. And when the level gets too low, my neurological system is going to sense that I need more, and so it's going to send a message to my adrenal glands to tell the adrenal glands to secrete, produce more, to release more. So it's this constant, process of negative feedback where my body's sensing what it has in it and adjusting the secretion through the adrenal glands to meet its needs. As far as adrenal drugs, they can either be synthetic or natural. All of the naturally occurring adrenal drugs are available in a synthetic form as well. As far as the glucocorticoids, they can be administered topically, and topical again means it's going to take application only where it's been applied. They can be systemic, where it absorbs into the bloodstream and affects my entire body. It can be inhaled, where I inhale it, and again, largely those are topical, where they're just trying to reduce inflammation in the airway by inhaling them. They can be nasal, which again primarily is topical, trying to reduce the inflammation in the mucous membranes of the nose by injecting them up into the nasal passages. And so you have some examples there. You have the mineralocorticoids, which are systemic. Basically, they get absorbed in the bloodstream. They affect my entire body. Aldosterone is the natural adrenal drug, obviously. And then fludrocortisone, Florinef, is the most common of the synthetic. It's a synthetic form of aldosterone. That's really all we have to talk about for this lecture. And then the adrenal steroid inhibitors, medications to inhibit the production of the steroids. Now, primarily what we're talking about is the first one up here, the glucocorticoids, because of their anti-inflammatory processes. But keep in mind, if I'm giving somebody glucocorticoids, if I'm giving them cortical hormone replacement therapy, primarily to treat their inflammation, the problem is they're probably getting some of the effects of the mineralocorticoid, and they're probably also getting some of the effects of the of the androgen, like I mentioned on the previous slide, that the precursor to the sex hormones. So keep that in the back of your mind as well. As far as mechanism of action, most corticosteroids exert their effects by modifying enzyme activity. So this is kind of where we have some of that concept that we learned during the pharmacology basics, where we talked about selective interaction and non-selective interaction, where drugs can work with specific enzymes or with multiple enzymes. And so we will be talking about that this morning as well. But again, the reason that we talk about this with this lecture is because the glucocorticoids help to regulate the inflammatory, the immune responses. As far as indications, multiple indications that adrenal drugs could be prescribed for, but primarily what we're talking about with this lecture is the anti-inflammatory processes to try to take the inflammation down. Now, all the drugs that we administer differ basically in the extent that they cause sodium and water retention, which deals with the mineralocorticoid activity, the aldosterone. As far as administration, glucocorticoids can be administered by inhalation, like I said, to try to minimize some of the inflammation in the airway. They can be used nasally to reduce some of the inflammation in the nasal passages. They can be applied topically for inflammations in the eye, on the skin, on the mucous membranes, in the ear. Now, what is depicted on this slide by these 3 points, these are all topical applications of cortisol, reducing the inflammation only where it's been applied. Now, obviously, we can give cortisol systemically as well. The oral form of cortisol is prednisone, that I already mentioned, and I'm sure you guys are already familiar with. I can give somebody a prednisone pill that gets absorbed into his bloodstream, and it has systemic effects, affects his entire body. And again, that can be used to try to reduce inflammation. You have an asthmatic patient who is in the hospital because of all the inflammation in his airway, and before he goes home, the doctor will probably send him home on some prednisone tablets to help reduce the inflammation in the airway over the next several days while he continues to get better. Now, the parenteral form of the systemic form of cortisol is methylprednisolone, Solubedrol, and this is the parenteral form, the injectable form. And now this is used primarily for those acute stages. I have somebody who has that active exacerbation flare-up of his asthma. We need to get him some methylprednisolone to reduce the inflammation quickly, and then when he goes home, they'll transition that to the prednisone tablets to send him home with. Or I have the patient with the vasculitis. I used that example in the first lecture that I posted. The person who has that severe inflammation of his blood vessels causing severe pains. So we get him some methylprednisolone, some injectable, some IV cortisol that goes into his blood vessels and takes the inflammation away very quickly. So again, just understand everything that's on the slide there is topical application, oral is prednisone, injectable methylprednisolone, and those two have systemic effects. As far as contraindications, as always, obviously, drug allergies. If somebody's allergic to these medications, don't administer them. The next one that you see listed there is serious infections. And again, I just want you to think briefly why. Why would somebody with a serious infection be contraindicated to receive cortisol? Hopefully, you remember enough about prednisone from working with it during fundamentals, I'm sure, that one of the side effects, one of the things that cortisol does is it suppresses your immune system. And so for that reason, if somebody has a serious infection, I don't want to give them cortisol that would suppress their immune system and make their body less likely to be able to fight off the infection that they're faced with. Okay. Also, you can see we use it cautiously in patients who have gastritis, reflux disease, ulcer disease. And the reason for this, again, is because of cortisol. Cortisol is a stress hormone, and so cortisol as a stress hormone results in a decreased production of my body's ability to produce mucus and protect the lining of my stomach from the acid. So as a result, giving somebody cortisol could make their gastritis worse, could make their reflux worse, could make their ulcers worse. Diabetes would be another cautious use of cortisol, again because one of the effects of cortisol as a stress hormone is it causes your liver to release stored sugar into my bloodstream to raise the blood sugar. So that would be used cautiously in a patient who's diabetic, who's having difficulty managing the amount of blood sugar floating around in the serum of his blood. And then you see used cautiously with cardiac patients, renal patients, liver patients. For this, I want you to think not just the stress hormone with cortisol, but I want you to think about the other one that I mentioned, aldosterone. They're going to get some of the effects of the aldosterone as well. They're going to get some of the reabsorption of sodium and excretion, elimination of potassium. And so if I have somebody who's a cardiac patient and his heart is already having difficulty pumping the amount of fluid that's in the body, and they're getting the effects of aldosterone, making the kidneys reabsorb more sodium. If you think back to fundamentals, when we talked about sodium's main role in the body is to move water. Sodium and water go hand in hand with each other. So if the kidneys are reabsorbing sodium, the kidneys are also holding on to and reabsorbing more water. And so if the person has cardiac disease, his heart is already having trouble pumping the amount of fluid in the vascular space, and now, because the aldosterone effects, the vascular space is filled with even more fluid. That's going to make his cardiac condition even worse. Same thing with the kidneys, same thing with the liver. As far as adverse effects, we'll just highlight a couple. Under cardiovascular there, you've got edema and hypertension, again, because the effects of both the cortisol and the aldosterone. You see electrolyte imbalances, again, because of the aldosterone, making your body reabsorb sodium and getting rid of potassium. So as a result, it can lead to hypernatremia, hypokalemia. Under central nervous system, you see mood swings. I would underline that one. Mood swings, nervousness, agitation. As you guys are probably familiar with from looking up prednisone, irritability, mood swings, emotional lability, going from one extreme to the other very abruptly, are very common side effects of somebody getting prednisone because of the cortisol. Under endocrine, you see growth suppression. We don't want to give people cortisol because it does suppress growth, so we avoid giving cortisol to to pediatric patients, to adolescent patients, as much as possible. Menstrual irregularities. This is where that aldosterone fits in. I'm sorry, not aldosterone, androgen fits in, that precursor to the sex hormones, because again, this affects things like the male sex hormones, the testosterone, that even women have a small degree of testosterone in their bodies, and the estrogen. So if we end up giving them adrenal drugs, there is going to be a little bit of the androgen in there as well, which can affect their menstruation. Hyperglycemia, I would underline that under endocrine as well. Like we already talked about, the cortisol makes your liver release stored sugar into the bloodstream, which can raise the blood sugar. Under GI, I would underline peptic ulcers. We already talked about that. The stress hormones, because of the sympathetic nervous system, it makes my secretion of mucus decrease, and so my body is less able to protect the lining of my digestive tract from all the acid and digestive enzymes that are in it, which can lead to ulcers in my digestive tract. Under integumentary system, very common, I would underline the fragile skin, the petechia. Again, this is from the effects of the cortisol. I would definitely underline poor wound healing because of the immunosuppression from the cortisol. I would underline the hirsutism, the abnormal growth, especially in females. And again, this is because of the androgen. If we have a female who ends up getting more testosterone than what her body's used to, she can start to develop some facial hair growth. So that's the hirsutism. Under musculoskeletal, I would underline both loss of muscle mass and osteoporosis. These, if you remember from looking up prednisone, as I'm sure you did in fundamentals, these are very common side effects of somebody taking prednisone. Synthetic cortisol, leads to a loss of muscle mass, leads to osteoporosis. Cortisol actually helps to bring down your body's level of calcium. We can actually give cortisol to treat hypercalcemia. So if I'm giving somebody cortisol, it's going to lower the serum levels of the calcium, and the body's way of counteracting that loss of calcium in the serum is to suck calcium right out of the bones to put it back into the bloodstream. And so as a result, that leads to osteoporosis, a loss of bone mass. Under ocular, it can lead to increased intraocular pressure, which is glaucoma. Again, that's because of the increase in pressure, from both the cortisol and the aldosterone, and weight gain. Now, the other thing I want you to keep in mind is, as I already mentioned on the previous slides, these are stress hormones. So let's say, I want you to apply this. Let's say that we have a patient who's receiving cortisol treatments. He's receiving some of these cortisol drugs because his body's not producing enough. And so he's regulated on the dosage that he's receiving, but under times of stress, normally my body would increase the production of those hormones. But now I've got a patient who's not able to his body's not able to increase the production of those hormones. So in times of stress, we would need to educate our patient that you might need to take an increased dose of your medications to deal with that stress that your body's trying to deal with. So he might actually start to develop some of the signs of adrenal drug insufficiency, like Addison's disease, during times of stress. He may be well regulated when everything's great, but when he's going through a divorce, all of a sudden he starts to develop signs and symptoms of Addison's disease because his body doesn't have enough of those adrenal drugs in its system. So he might have to start taking more of his supplemental drugs. So just keep that in mind. As far as interaction, multiple drugs, diuretics, especially your non-potassium sparing diuretics, your thiazides, your loops that we'll talk about later this semester. Again, it can lead to things like the hypokalemia because of the excessive loss of potassium. Remember, the aldosterone causes your body to reabsorb sodium and lose potassium. So if I'm already losing potassium because of the adrenal drugs that I'm taking, the aldosterone, but then also we add in a diuretic that causes the body to lose even more potassium, like Lasix, it can lead to hypokalemia. Same thing with the hypocalcemia that I already talked about. Aspirin and NSAIDs can increase the chance of gastric ulcers, peptic ulcers, already talked about that. Anticholinesterase drugs can lead to increased weakness. Anti-diabetic drugs can reduce an elevated blood glucose levels, kind of already talked about that. Prednisone, the oral form of cortisol, the most commonly used oral glucocorticoid for anti-inflammatory immunosuppressant purposes. Already talked about that. If the person has adrenocortical insufficiency, prednisone is not sufficient to replace the adrenal drugs. Florinef, fludrocortisone, is the drug of choice for that. We don't really have to talk too much about that, but what I do want to talk about with this is something that you're already familiar with, and that's the fact that whenever the oral cortisol replacement, prednisone, needs to be discontinued and taken away, we cannot do it abruptly, which I know you're already aware of. Because again, the reason is cortisol is a hormone my body naturally produces. If I have a patient who starts to take a cortisol replacement like prednisone or methylprednisolone, the IV form, then the body basically says, I don't know why I'm continuing to make all of this cortisone on my own, all this cortisol on my own. You're giving me everything that I need, so the body stops its own production of cortisol because you're replacing it. If all of a sudden I were to stop taking that replacement abruptly and suddenly, then my body would go for a period of time with no cortisol in it whatsoever, which could lead to an Addisonian crisis, severe symptoms of Addison's disease because my body has no cortisol whatsoever. So for that reason, when it comes time to stop taking the prednisone, we have to make sure our patient knows to taper the dosage. Stop taking it a little bit over time. Go from taking 10 milligrams a day to 8 milligrams to 7 milligrams to 6 to 4 to 2.5 to 2 to 1 to 1 every other day. But we have to slowly start tapering that dosage off so the body can kind of kickstart its own production in the meantime to make up the difference when I do stop taking the prednisone. So make sure you understand that we have to taper the dose when it comes time to stop taking it. The injectable form of cortisol, like I already mentioned, is methylprednisolone. This is Solumedrol. This is the most commonly used injectable glucocorticoid, again, primarily used for immunosuppression and anti-inflammatory. It's used intravenously. Just be careful, like the slide says, the additive that they put into the injectable forms does contain benzyl alcohol, and so we can't give that to children, to pediatrics. Because of that, that benzyl, it can lead to actually a life-threatening problem. Also be aware that there is both Solumedrol and Solucortef. Solucortef is basically IV hydrocortisone. And make sure that you understand they're not interchangeable. Solucortef is not Solumedrol. Solumedrol is actually 5 times stronger than Solucortef is. So again, they're not interchangeable. You'd want to make sure that you're looking at the dosages between the Solucortef and the Solumedrol. As far as implications, just hitting the highlights with a couple of these adrenal drugs. Again, make sure that you're doing a very good physical assessment to get that baseline data. Baseline, like we mentioned before, is so crucially important because it's your baseline data. That's the only way that you're going to recognize when something is in fact concerning to you, is I look at my assessment now and compare it to what my baseline was earlier. If it's significantly different, that's significant. That could indicate a potential problem. So make sure that you're getting a good baseline data. Make sure you're looking at your laboratory studies, again, so you can start to recognize when something's changing, when something's becoming concerning. You're making sure that you're monitoring during therapy for development of edema and watching their electrolytes and their lab work to start to pick up on things like hypocalcemia, hypokalemia, hypernatremia. You're watching those closely. Be aware that they can change make a change in the serum glucose, like we already talked about. They can make a change in the electrolyte levels. Systemic forms, again, can be given orally, intramuscularly, intravenously. We can give them rectally, but not subcutaneously. Important for you to understand. We're never going to give Solu-Medrol as a sub-Q injection. If the adrenal drug is being given topically, to try to reduce the inflammation in the nasal passages, obviously it'd be a good idea to have the person to blow his nose before I spray the cortisol up into his nose, because we want the cortisol to actually make contact with the mucous membrane so it actually has an effect. If I just spray that in his nose and his nose is all clogged up with mucus, it's not really going to do any good. So have him blow his nose out first. The next bullet point I would put a star next to, very, very, very important. If the person is using an orally inhaled corticosteroid, he's got asthma, and so he's taking an inhaled form of corticosteroid to prevent inflammation, to manage his asthma symptoms. Obviously, he's going to get some of that powder passing through his mouth on the way down to his lungs. And you want to make sure that after he uses his inhaler, that he rinses his mouth out very well afterwards. Because again, a very common side effect of corticosteroids is it suppresses your immune system. And as we said during the first couple weeks, you and I harbor over 80% of the microorganisms, the pathogens that cause pneumonia, right in my mouth. So if I'm suppressing the immune system, all of those microbes in my mouth can start to prosper and grow, and it can lead to fungal infections in the mouth, in the throat. It can actually lead to the development of pneumonia, to an extreme form. So make sure that a person who's using a corticosteroid inhaler is rinsing his mouth out after he uses his inhaler. If the person is receiving corticosteroids, make sure that he's avoiding contact with people who have infections. If you know somebody has the flu, stay away from them. Because again, corticosteroids, as a side effect, suppress your immune system. I don't want to take somebody receiving corticosteroids who has a suppressed immune system and put him in contact with somebody who has an active infection where he's more likely to contact that. Make sure that patients are taking their adrenal medications at the same time every day. I would underline that, usually in the morning with meals or food, but the important thing is at the same time every day. Again, these are hormones that my body naturally produces, and typically my body naturally produces these on a diurnal pattern. I increase my production of these hormones from the adrenal glands first thing in the morning and later in the afternoon. So in the morning I produce a lot, and then the production kind of tapers off through the afternoon, and then later in the afternoon my body increases production again and then tapers off. So the important thing is to take it at the same time every day. The next bullet point, like we already mentioned, I would put a star next to this as well. Make sure you do not discontinue these drugs suddenly, but you have to taper the dose. We already talked about that. And then obviously monitor for the therapeutic responses. Are we getting the anti-inflammatory properties that you want from the drug? And then monitoring for any of the adverse effects, looking at the electrolytes, making sure they're not developing systemic infections, edema, making sure that it's not making their cardiovascular condition worse, those kind of things. Again, if you have any questions, problems, issues, anything, you can please contact me. You can post your questions to Canvas, and I will try to get back to you on those. Go ahead and take another short break, and we'll finish this off with the anti-inflammatory drug lecture. And again, I'll have to kind of start from the beginning and fast forward to that part real quick. I can't pick right up there.